Okay. Here are my disclosures. So I'm going to start off with a case. Some of you may be familiar with this case. This was a guy with ulcerative colitis, severe flare. Initially started off with proctitis. Now it's extended to the whole colon. He's steroid dependent. He started on azathioprine. He's on appropriate weight-based dosing, and after 3 months, he's still steroid dependent. You check a chest x-ray and a PPD, and that's negative. You start him on infliximab. He gets his 3-dose induction, and 8 weeks after starting, he's better, but then 2 weeks later, he calls with fever, myalgia, chest discomfort, dry cough. You see him that day. The chest x-ray is read as, quote, negative, but a chest CT, because he's having ongoing symptoms of pain, show multiple nodules, mediastinal lymphadenopathy. ID is concerned about a granulomatous infection like histo, but his histoserology is negative, and he's not responding to itraconazole, pulmonary cesium. They do a bronch, and then it turns out the sputum culture that you had gotten when he originally presented is growing out Mycobacterium tuberculosis. So at that point, you stop all of his immunosuppression. You start him on 4-drug therapy for his Mycobacterium. 2 weeks later, he gets arthralgias and fevers, and the infectious disease docs are thinking this is an immune reconstitution syndrome, so you start him on low-dose prednisone to manage those symptoms, and he eventually settles down. He does eventually require a colectomy, but I think this is a good example of a patient who had a serious and opportunistic infection, and the only way you could have managed this appropriately would have been to stop all of the immunosuppression. So again, an opportunistic infection is one that is caused by an organism which normally under immunocompetent circumstances wouldn't cause disease. A serious infection is one that results in hospitalization or IV therapy or results in disability and death. And not all of these don't necessarily overlap exactly. You can have an opportunistic infection that's not serious and a serious infection that's not opportunistic. And not all of our patients are immunosuppressed, but they often have risk factors for that, including older age or malnutrition, comorbidities, or they're on certain medications. And I would argue that the title of this debate shouldn't have just included immunomodulators or biologics. It should have also included corticosteroids, because I'll show you data that that's probably the biggest factor in all of this. And the problem is that there is no one way to predict in an individual patient how much immunosuppression they're going to have, and there's no test that we can do to measure the level of immunosuppression, so we have to do some guesswork. We know from several studies, including this case control study that we did of cases with opportunistic infections and controls that didn't, that age is a risk factor for an infection. And as you go up by quartiles of age, you can see that you march right up in terms of relative risk of infection, such that the oldest group of patients above age 30 are 3 times more likely than the younger patients to have an opportunistic infection. We also did a study at Mayo several years ago looking at outcomes of patients over the age of 60 on biologics, and we saw that the older patients, 27% of them had a serious adverse event versus only 10% of the younger patients, and most of those adverse events were infections, 22% versus 8%, and when you work out the hazard ratio of time to serious infection, the older patients are anywhere between 70% and twice as likely to have a serious infection. We also know from case control studies, this is one example, that the more medications you're on, the more likely you are to have an infection, and you can see that that ranges from 1.0 for a 5-ASA, which makes sense, to as high as 4 or 4.4 for methotrexate or infliximab. And furthermore, if you're on multiple medications, your risk of an opportunistic infection goes up. And I know this study was criticized earlier today, but it does sort of prove the concept that more immunosuppressive medications may very well increase the relative risk of infections. And the treat data show that yes, while infliximab and immunomodulators may contribute to infection. By far, the one that contributes the most are corticosteroids, where you have a 2 to 3-fold increased risk of a serious infection, and you also have a doubling of mortality if you're on corticosteroids. So we have to include that into our decision-making when we're talking about withdrawing therapy. This was a study in the RA literature showing that high-dose infliximab increased the risk of serious infection by a factor of 3 and also increased the number of TB cases that occurred. And this was a study that Jim Lewis was involved in, among others. This was looking at a large database of Medicare and Medicaid patients from different parts of the country, showing that both anti-TNF therapies and thiopurines seem to result in increasing risks of hospitalization for serious infections. And so there wasn't any significant difference between the two groups, but in both groups you can see that there was an increased risk, such that by the end of the year, about 10% of these patients had developed a serious infection. So I'm just painting the picture here that obviously these medications contribute to the risk of infection, and therefore the corollary is if you get one of these infections, you probably need to discontinue the medications in order to help resolve the infection. We know that azathioprine in particular and 6-MP increased the risk of certain viral infections. This was a prospective study from France showing that patients were more likely to have viral URIs or herpes virus, herpes simplex flare-ups, as well as viral warts if they had been on azathioprine relative to not. And on a related note with HPV, cervical dysplasia in some studies, but not all, is increased in women who are on immunosuppression, and it's recommended that women on immunosuppression with IBD get regular cervical cancer screening because of this issue. If you haven't had a chance to look at this article, it's an ECCO guideline. It came out 4 years ago. It's a massive document. It's like 45 pages long, but it contains consensus statements about how to prevent and manage a whole variety of opportunistic infections. And so I tried to condense a lot of this data onto one table, but this was looking at all the viral infections. And in the first column, it tells you whether or not you should screen for this particular infection before starting the immunosuppression, whether or not you can vaccinate the patient for that particular infection, and then if they develop the infection, whether or not you should withdraw immunosuppression. And you can see it is all over the map, but in many cases, it is recommended that you withdraw the immunosuppression if you develop this particular infection. For example, CMV colitis. You should really make an attempt to hold therapy while you're treating that patient with an antiviral therapy. And if they have severe cases of herpes simplex or zoster or EBV infection or HPV infection, you should also seriously consider withdrawing immunosuppression. And obviously, if you have JC virus and develop PML, you're going to withdraw the natalizumab. So in many of these cases, not all, you really have to work on this. Now, Clostridium difficile is controversial. We know that this is particularly increased risk in patients with IBD. This results in flares and hospitalizations. It makes their hospitalizations lengthier. Often these patients have a higher risk of surgery. There's controversy in the literature about whether or not immunosuppression needs to be withheld in these patients. There was an Israeli study suggesting that there was a composite endpoint of death and whether or not you were on a ventilator in the ICU, and this suggested that continuing immunosuppression was a negative. On the other hand, there are many studies suggesting that you can, and I think C. diff is one where you're going to have to manage that on a case-by-case basis, and ideally, you just want to get rid of the C. diff, and you might want to think about a fecal transplant if you're having trouble eradicating that infection. And just for anti-TNF therapies in particular, we have a variety of granulomatous infections like tuberculosis, listeria, and then for invasive fungal, you've got histo, cocci, candidiasis, aspergillus, pneumocystis. So all of these are of concern in patients on anti-TNF therapy. And most of you, if you live in the Histo belt, you already know this. It's generally the Ohio River Valley and the Mississippi River Valley, and Cocci is mostly in the southwestern and the Central Valley of California. So you have to be aware of these. There's debate in the literature as to whether or not you should screen for Histo or Cocci in advance in these endemic areas. I think there's not really a consensus that has been arised on this. There are a variety of fungal infections that have been reported. This is one example of a study that looking at MEDLINE and PubMed up until 2007, and you can see Aspergillus, Candida, Cryptococcus, Blastomyces, Cocci, Histo, etc. So these are of concern. This was a study looking at calcineurin inhibitors showing several patients who had serious fungal infections as well. For tuberculosis in particular, I think you have to make a distinction between whether or not the patient has latent tubercular infection or active infection. If they're latent, you want to get them on their isoniazid prophylaxis for at least, now in some of the society guidelines, they're saying get on that for at least 3 weeks, then you can start your anti-TNF therapy. And of course, if they have active TB, they need to be on their multi-drug therapy for a minimum of 2 months before you would consider starting them on anti-TNF therapy. The ECCO guidelines also delve into the various fungal infections and tuberculosis and C. diff and other bacterial infections, and it really is an individualized basis for many of these infections. You have to look at the whole picture with your patient. How sick are they? Can you hold the anti-TNF for several weeks? But in general, you're probably going to have to hold something while this patient is being treated. So to conclude, these are serious infections that can occur in our patients, older age hospitalizations, steroids in particular, but other immunomodulators and biologics. The risk of infection is probably no higher with anti-TNFs than with the thiopurines. You have to stay vigilant with your patients, and I think you have to weigh that benefit to risk ratio, and the decision to stop immunosuppression is going to be individualized. You need to get the help of your ID colleagues. Probably you're going to have to stop something. So I'm going to stop there. Thank you.